Hello and welcome to the Independence Age Friday briefing. Today we're focusing on test and trace. Since the very beginning, Independence Age has been calling for an effective test and trace system in the UK. Countries that have implemented just such a system, like Taiwan and South Korea, have seen many fewer deaths, many fewer cases indeed, and less economic damage. There is no doubt that lives here could have been saved had the UK as a whole had an effective test and trace system. But it's not too late. The vaccine rollout continues apace, but an effective testing infrastructure is still absolutely vital if we really are to get on top of this pandemic. So today, Independence Age is meeting with representatives from Leicester and Newham, who will tell us about how those towns have implemented effective test and trace systems, setting an example which the rest of the country really should follow. So we're going to start today with a brief introduction to testing and tracing in Leicester from Professor Gabriel Scally, who's joined by Liz Rodrigo, Public Health Lead Commissioner, and Ivan Brown, Director of Public Health in Leicester, and also Professor Azar Faruqi as well. Over to you, Gabriel.
Thanks very much, Alice. And it's great that we're talking about test, trace, find, test, trace, isolate and support, because the need for it is not going to go away. We're likely to be moving into a situation where while we see a big drop in the number of cases, hospital admissions and deaths, hopefully, we will undoubtedly see flare-ups and outbreaks. So we're going to be very, very reliant on what is going on in terms of the public health response at a local level right across the United Kingdom. So it's great pleasure today that we've got two teams of people to speak to us. And first of all, we're going to hear from Leicester and Ivan Brown, who's the Director of Public Health in Leicester, has been one of the few DPHs, I think, that I've seen on the television quite a lot, always speaking very eloquently about the difficult times they were having in Leicester and how they were coping with it. Ivan, would you like to introduce your colleagues briefly and then speak to us?
Thank you very much. So I would just, in this presentation, we're just going to give a little bit of a flavour about what we're doing in Leicester. It's always good to have people that are on the front line doing this, and to that end, I'm also joined, thankfully, by my lead commissioner around test and trace, and also our public health support in relation to that. But I'm going to share a screen, share my presentation with you, and then from there, we will just walk you through some of this information that we have about Leicester. So first of all, what I would just want to say to you, first of all, is just getting a bit of a flavour about Leicester as a whole, so that you have an idea about what we're experiencing. Can I just check that you can see my screen at the moment?
Not yet.
No,
okay.
We can see you, Ivan. We can't see your...
Okay, just hold on one moment and I'll make sure I got that up for you. Just wait for a second. Right, here we go.
We can see it now, Ivan.
Excellent. Good. I'm just going to... So just a bit about Leicester, and it kind of explains why it's particularly important to us. Large Midland city, 380 residents, but if we're talking about registered population, we're talking close to 400,000. Important about the city is it's a really compact city. It doesn't have, lots of suburbs that sort of mitigate or water down the experiences of the city. One of the most ethnically diverse cities in the country, but really it's got real high levels of deprivation, highly mobile employment picture, so people move all over the place in order to get employment, not particularly at that high level. People need to go out to work, lots of concentrated housing, low levels of English literacy, being a diverse population and a deprived population, but also probably of significance is it's an area of what they are calling enduring transmission, an area where we have experienced COVID disproportionately compared to other areas. So just in terms of the context of what drove us to our local testing approach, At the end of June, Leicester was identified as an area with a high rate of COVID cases. Interestingly, at that time, it was 135 cases per 100,000. It seems like a long time ago since that was considered to be a particularly high rate. But what became very clear to us when we were put into a local lockdown, as we were the first city and perhaps the only one that's been in a local lockdown, is that the need, what was driving was transmission of the virus in households by and large for us. And it was very clear to us that in order to get on the front foot of this, we needed to have a fast and a clear system, a real local approach to contact tracing. And what was really key was that we needed to have an approach that actually linked into our local support services. And we wanted to make sure that that was also linked to local expertise, local knowledge to be able to drive that. So just in terms of the timeline of what we experienced is, we set up a tracing system with the support of Test and Trace. We started on the 17th of July, and that was having cases passed to us after 72 hours. So if the national system couldn't get there in 72 hours, they passed them through to us, and we tried to follow those up. All the time, I think we were really driving to get earlier and earlier data so that we could pick it up. So by the time we got to August 2020, we had that time reduced to 48 hours. We were the pilots for each of these. By the 7th of December, we were getting the data after 8 hours. And now since January 2020, we are at a local zero. So we get the data straight away. And we run a repeat of that every hour between 8 a.m. and 4 p.m. And the results for us have been incredibly strong. We're receiving now 98% of all of our local data. We're managing to get to 91% of our cases within a 24 hours of a positive result. And we're getting to 98% of all cases within 48 hours, which is a considerable improvement as to where we were at the beginning of this. I'm going to hand over to Ed Quick in my team, who's been really instrumental in just talking about how the difference that this has made in the process that we have. So Ed, can you come in?
Thanks, Ivan. So I'm just going to quickly talk about the process. Now, rather than talking you through a process map, which could be fairly complex and sprawling, I'm just going to look at the key points where we feel having this process set up at a local level is perhaps beneficial. To begin with, once we receive the data from the national team, we're able to cross-check it against our local systems, which means that we're able to find alternative contact numbers, alternative addresses, and a deeper level of information about the people that we're trying to get hold of. It's part of the reason we were able to get hold of those more difficult cases to begin with, but it rolls on to getting hold of all of the cases that are passed to us. There's also a sense of local responsibility. The people who are handling these cases at a local level are people that live in the city and are people that care about these outcomes very, very deeply. Once we've received the data, we go on to contact the cases. We're using a local telephone number, which we feel has been better received than the national number that's used by the national team. And of course, our team has a lot of local community understanding, not least language skills that relate to the city, such as Gujarati, Hindi, Arabic, and Eastern European languages. Our process then sees the returns from investigators come through quality checking and further investigation. So our team, if we can't get hold of somebody, we don't just send that off as a statistic. We ask as a management team why we haven't been able to get hold of that case on a case-by-case basis. We look at what else we can do to try and find them. How else can we try and track these people down to give them this important guidance and support information that we have to offer. And that's been particularly important against the backdrop of multiple contacts to households. So early on, there was a lot of concern about people being repeatedly contacted, whereas we were able to look at the data and sort them into households so we could get hold of one household cluster in a single instance. Then, of course, we've got our ground team. We can send people out to the streets. If people aren't picking up those telephones, we aren't able to get alternative telephone numbers, we'll send our team out to knock on their door and provide that support and that isolation guidance on the street, and also our local connections, so we can escalate cases directly to our public health team, directly to our schools.
Thanks, Ed. Liz?
I'm on the next slide as well. Sorry, Ivan.
Sorry. There you go. Sorry, it seems to have frozen at the moment.
So while I've been trying to track, there we go. So what we're looking at here is what we've needed to set up to do this. The first thing is that we needed a team able to work 7 days a week, because COVID does not stop spreading just because it's the weekend. And we've also had to have built-in surge capacity. And again, this is something I think that, that it was highly publicised around the national team, with agents having nothing to do for long stretches of time. And we've seen that too. The case numbers vary hugely, but we need a team that's large enough to be able to jump onto spikes of cases. The benefit, I think, of having it set up at a local level is we're able to create dual roles, and we're able to bring people in from other areas of the local authority to join us in contact tracing when they're needed, whilst we're still working efficiently when the numbers are low. The local understanding, that local commitment, I've already touched on the previous slide, but I can't emphasise how committed the team are. And I think a large part of that is that the people they're speaking to are people from the communities that we live and work in. The ground team obviously is an essential part of the contact tracing setup. Without a ground team, our no trace percentage would be much higher than it is. The data infrastructure too is important, making sure that there's seamless transition between ourselves and CTAS, and of course that we're working within the GDPR guidelines. We've got a lot of sensitive data being used in these in this project, so we've had to be very careful around that. The support infrastructure is crucial. So we're not just reaching out to people to tell them they're positive and they need to isolate. We're also bringing the full scope of the local authorities' support offer, and that includes delivering ambient food to people, which Liz will touch on shortly, but also mental health support, and effectively anything that people need so that we can make sure that they're isolating safely. And then, of course, there's the communication network within the authority. So the track and trace team working directly with public health, directly with our PFA teams and teams throughout the authority, and with partners to support those who are isolating.
Thanks, Ed. So Liz, just picking up the things that are missing.
Okay, so it sounds like this was all really good and it's rosy, but there were trips and hazards along the way. We had some structural issues. It's a disjointed system out there. There's Public Health England, NHSE, Test and Trace, local authorities and DHSE. Quite unclear who does what and how you get in contact with different people when you've got a problem, and how you can link everything quickly. Because in the middle of the pandemic, you can't do things slow. You have to just get on and get on with it. And therefore you need to know who to get to. And that has been quite a challenge for us. Not only that, I think it's difficult to get your local voice heard amongst all of the national players and those multiple organisations, some of which are not necessarily are focused on their own targets, on the performance targets they've been given to be able to get the job done. And sometimes they're taking off some of the easy stuff and leaving the more difficult stuff to the local areas. For instance, at the beginning, we were only getting the cases that nobody could get hold of, but then we would be performance managed on the ones we couldn't get hold of. So that was an issue at the beginning. Somebody's asked me to put my camera on. I'm on now, sorry, but I'm looking in the dark. Not only that, the national IT system's not fit for local use, so it's quite difficult to use it locally, and it doesn't fit in with what you want to do. So if we wanted to look at a case and then we wanted to look back at it at the beginning of the pandemic, we couldn't do that. Once we'd completed the case, it'd be gone, so we couldn't link it with anybody else. It was a very difficult system to work with. And often it would crash. So we'd be expecting data through in the morning. We maybe didn't get till 4 in the afternoon, which was absolutely useless because you'd spent the whole day waiting for the data. And of course, that case was that much staler by the time you got it. Could have been out at work, could have been doing anything. Capacity planning has also been difficult. For instance, on the 31st of December, which is a lovely day for us to be enjoying the end of what we've hoped was 2020, and the end of the pandemic, we got 189 cases where we normally got 40. And that means that you've then rushing around trying to get staff on New Year's Eve, knowing the next day is a bank holiday, to try and sort things out. That was a complete surprise for us. And Ed got quite a few more grey hairs that day, trying to work with the team. The national system has been imposing lots of IT changes throughout, and sometimes the local team would not be informed of those until the day before. So it's really difficult to work at both a local and national level. And currently and ongoing, we're still having trouble with the testing system. So we're getting delays in getting results of people who've been tested. So it might be 4 days before it comes down to the team that somebody's got a positive result. That means that person may not have known their result for 4 days, or they may have known it and they've been out. So that there's still problems with the system out there. Ivan, could we go on to the next slide? So it's not all negative. Leicester, we've done lots of innovative things that we're very proud of, things that have been, we've started off and have maybe been taken on. The team do support calls with all the positive cases now after 3 days. So a local person will ring up local people on day 3 and say to them, are you okay? Is there anything you need? Is there anything the family need? And since the 1st of April, we've delivered 12 ambient food boxes supporting 30 household members, 24 long-term food support packages, which has supported 56 household members. This is really important because people need to stay in their houses and sometimes it's difficult for them to get out. If they've never done online shopping or haven't got the finance in order to do that, that makes it really difficult. So these things actually support people remaining in isolation. We have spreadsheets of different exposure groups that we keep, and they're sent to different cells in the local authority for support. So our school team get every single child's case. They ring the school to make sure the school knows of the cases and are able to support any bubbles that might need to be isolated. The care home team do similarly. The infection prevention and control team visit their care homes when we've got any cases, whether that's staff or residents, to make sure that everything is okay there, that the processes that they've got in place are okay as well. And with workplaces, we're working closely with our local Public Health England team and our regulatory services team to reinforce work in factories and warehouses. As Ivan spoke about, in Leicester, people don't always work in Leicester. They may work in some of the large warehouses on the outskirts, and it's important that we work outside of the city as well as inside the city in order to be able to identify people where they might have contracted COVID. The other team that we've got is we've got a team that actually work with people who haven't got right to remain or are in difficult circumstances, and we work with them in helping those people to isolate as well. In recent weeks, I'm sure you will have seen on the TV, Leicester's become quite famous because we've got quite a lot of international cases in Leicester. We noticed this about 3 or 4 weeks ago, that we were getting very high numbers of international cases. And we almost immediately instigated at visits to homes for every single case that is an international case to deliver test kits to families, so that the family contacts would have a test as well as the person that was the original case. And through that, we've identified quite a lot of cases that would not have been identified that are linked to international travel. It's opened up channels for more joint up working and raised issues at a national level. Ivan, I'm over to you.
Right, thanks. So just to finish off very quickly, what was the learning? So the learning is that we've got from this is that we could get staff, we could train them up very quickly, they could become very skilled in this work. We could work very collaborative with health protection teams and use that expertise to inform our response. We've developed a good relationship with the national team. So now it's taken a bit of time, we've got to where we're co-creating in terms of what we need to do. The importance of data sharing and the staff welfare and capacity is a big issue, because this is a long-term piece of work that you have to do. And what's made this really work was local knowledge, understanding the area, the passion and the commitment of the people that were involved, and additional information that we hold within local authority databases, which means that we can go further in order to be able to track down people. And as we said before, a local number helps, it being the council helps as a recognised way through. And we're able to call back to people and have meaningful conversations with them. And I suppose the final slide is just what we would want to get from it. I think what we'd ask for the future is that people trust local authorities. We've done contact tracing, we've got good links in terms of talking to people. It's a united system is what we need to get to, and we need something that's fast and responsive, and I think this is the route that allows us to do it. And it provides ongoing support, response for people locally, whether you're in a school, whether you're in a workplace, and we need something that's fast and reliable response that wraps services around. So sorry we went slightly over, but that's our presentation. Thank you very much.
Great, thank you very much, Ivan. If I could just ask a couple of quick questions before I hand over to Stephen Riker and we hear from Newham. One is, tell me about budgets. Have you a blank check to pay for whatever you want to do? How is that handled? Well,
the reality is that we are using whatever resource we have. So we don't have a blank check for this. No, we don't. So all of any contained money that we have, we do that. If it's our own local money, because we've had to reallocate staff from customer care services, our ground team uses people from sports services, from museums, from all over the place in order to be able to do that. So, but we need to just step up the response, appropriately. Funding would help, of course.
But I thought there was unlimited billions going into testing and tracing.
If it is, it's not necessarily coming to us.
Okay. I have a question about, I'm very keen on the testing of high-risk people as soon as possible. And high-risk people, really in this context, are close contacts of those who have already tested positive. But that hasn't been the central position. The central position is being that they would be, those high-risk individuals will be told to isolate and only come for testing if they develop symptoms, but we know a lot of people are asymptomatic. How have you handled the decision about who to test, and do you test close contacts?
Yeah, so when we do the door-to-door work, and which is the bit that we started, when we ask people, we don't just ask about people who are positive, we do ask that, but we also provide actually it's PCR tests for individuals who are in those households as well. Because sometimes there are barriers to people being able to get out and test also. So I think that you need to think of those as family units, as a single entity, as opposed to just the individual, because we know certainly in the city, it's very much driven by inter and intra-household transmission.
Yeah, okay. And a final one, there was a lot of mention there of international travel. Is that, what do you think is the current driver at the moment?
Yeah, so as the numbers start to come down, I think areas like Leicester that are quite international cities and other areas, I think, have seen the proportion of cases that are linked to international travel increasing considerably. So I think for us, that is the one that we are quite focused on at the moment.
Great, thanks very much, Ivan. Can I hand over to Professor Riker?
Hello. And first of all, thanks so much for that, I think, quite compelling demonstration of why local works, why it's so much more effective to have a testing and tracing system based on local public health, who know their community, who are trusted by their community. One of the points that Independent Sage have made throughout, however, is however good your testing and however good your tracing, you're not achieving very much unless you also get people to isolate. So the government spends, as Gabriel put it, he put it untold billions, 37 billion we are told, on test and trace, but aren't prepared to put the funding in to support people to isolate. And the funding available at the moment is derisory. Only 1 in 8 workers is eligible. Of those, a minority who apply actually get it. And that doesn't even start to talk about other things like providing support for caring responsibilities, accommodation, and so on. And just as Leicester demonstrates how what is being neglected at a national level is being taken up by local authorities, so Newham, I think, is a shining example of what supported isolation could look like and should look like. So I'm quite delighted that we have with us both the Mayor of Newham, Roxana Fiaz, and the Director of Public Health, Jason Strelitz, who are going to tell us about what's been going on in Newham.
Thank you very much, Stephen, and thank you to all members of the Independence Age for inviting us to your session this week. And as I mentioned to Stephen, I'm an avid follower of the indie sessions, and I use it as my running soundtrack every Sunday since the start of the pandemic, albeit he thinks I'm a saddo. Look, one of the things that has always been a feature of your discussions week in, week out since the commencement of the pandemic and our response to it here in this country has been the absolute importance of test, trace, support and isolation as part of the general strategy that you've been advancing to national government around zero COVID-19 strategy, and notwithstanding the absolute convincing evidence base that has fallen largely on deaf ears, and I can say that, but Jason Strelitz can't because he's an officer of the council. The challenge that has posed to us at local authority level has been significant and great. And what we're intending to do over the course of the next several minutes, myself and Jason will be doing a slight double act to just set out, in a similar vein to Leicester, some brief top lines with regards to the Newham context, and then how we've built and baked in that isolation support feature, but in a very enhanced way because of the characteristics of Newham. So if you can just bear with me for 2 ticks, and I'll be sharing my screen, and then hopefully everything will be smooth. There you go. Super. So we're going to be, let me just quickly, right, so we're going to be going through our test, trace, support and enhanced isolation regime that we've put in place in Newham, which is all about, as you can imagine, supporting residents to stay safe. And one of the things that we were very clear about from the outset of the COVID-19 pandemic last March, not least because of the pre-existing issues of deprivation, poverty, health inequality, all those social determinants that we knew would pose real risks and vulnerabilities to our resident community. We knew that we had to maintain that consistent imperative to save lives and to mitigate against the spread of COVID-19 in the community. And in terms of the, and it doesn't move. Sorry, 1 second. Let me just go to the next slide. Now it does. So yeah, I just really wanted to set out some really important context about the Newham picture. You've heard from colleagues in Leicester about the characteristics of that population, and I would like to add that in a lot of respects, there are significant similarities, but in very specific ways, we have some sharp sort of contours of deprivation that aren't seen elsewhere in the country. Newham, comprising of 2 constituencies, East Ham and West Ham, sit within the top 10 most deprived constituencies in England and Wales. We have some 68% of our resident population that, when you take into account household costs, they technically are defined as living in poverty. We have 7,500 children, comprising of 5,500 households living in temporary accommodation. That is more than the entire north of England combined. Our weekly earnings is significantly lower than the London average. When you take into account gross household income of a Newham resident, the average in Newham is £19,325 per year, relative to the 29,500, which is the London average. So you can already note that we have a very vulnerable, in economic terms, community. And during the period 2018 going into 2019, very much pre-COVID, as part of our anti-poverty approach here locally, we evidenced that up to 36,000 residents of ours weren't even being paid the legally required national minimum wage, let alone something that we advocate here locally, which is the London living wage. And we have significant diversity. You'll see here on this slide the over 100 languages, and when you include dialects, we have some 242 dialects spoken, and a majority of our resident population do not have English as their first language. That very much brings to the fore issues of inequality of access, which is very much evidenced in our health inequality picture here in Newham. We have amongst the highest rates of severe respiratory conditions because of toxic air pollution. 4,500 children are taken into hospital each year because of vehicle fumes. 111 adults die each year prematurely. And all of those things we were contending with and being challenged by, and we were addressing pre-COVID. So when COVID hit, we knew that we would be severely impacted, and that has informed all of our approach to the wider test, trace, support and isolate piece in Newham, because of the economic vulnerability that exists, and also because of the insecurity of jobs, which could also be a facet of modern day slavery. We've got the highest number of no recourse to public fund families anywhere in the country, and we have the most overcrowded household ecology here locally, and that lends itself to a whole range of different health risks. And what you'll note here from this slide, notwithstanding the percentage of workforce occupancy, you'll note on the first bullet point in that first quarter of the COVID-19 period from March, we at one point reached the worst standardized mortality rate in England because of our deprivation, and hence that we launched a COVID-19 deprivation premium, where we were lobbying government to give us more and over and above what they were giving to government because of the deprivation features that were pre-existing. And that has, as I mentioned, informed our whole regime here locally. I know one of the things that the Indie Sage have been calling for, as mentioned previously, this zero COVID-19 strategy. And one of the things I said to Jason very early on is, in the context of Newham, located in, this global metropolis, which is expanding, where we are very much seen as a place where London is moving to, where we have some of the most significant and principal transport hubs, Stratford Station, Stratford International Station, and Canning Town. We have a lot of commuting, a significant number of our workforce, of the workforce for London in the public health sector, and that presents a whole series of risks. And very early on, as I was saying, I had said to Jason, the Indie Sage a lot are talking about, zero COVID-19. Can we deploy that strategy here in Newham? And that's difficult in the context of a global city that is London. And I wish, in the face of the transmission rates that we got to, certainly as we ended 2020 and entered into 2021, where it was going into over the thousands, it was something that we could do. But what we have done is mitigate the inability to approach a zero COVID-19 strategy by ensuring that our test, trace, support and isolate provision is absolutely on point. And here you'll see that we cover off in 5 principal areas, which Jason will talk through in a bit more detail, around doing the basics, obviously getting tested, encouraging through our mobilisation of the community through COVID-19 health champions, and also now with vaccines, we've got vaccine peer support network, but also more importantly, in light of the housing situation here in Newham, high numbers of multi-occupancy households, multi-generational, the support that's required with that isolation piece, and feeling able and confident as members of our community, that the council and our public health team and the wider voluntary community sector is here to support you, because we are one family in the face of the challenge that is COVID-19. So I'm going to be passing over to Jason, and he will talk through the genesis of the enhanced isolation support. It is the only, we are the only local authority presently that is supporting by placing or offering hotel provision to those individuals who are in households where it's difficult to isolate, with moving out for the period required in order to get better. Jason, over to you.
Thanks a lot, Roxana. Put simply, if I get a call as a director, as a well-paid, securely employed director of public health, if I get a call from Test and Trace that I need to isolate, it's a pain. For many of our residents, it represents a massive challenge in terms of how they're going to put sufficient money on the table, pay their rent, feed their family, pay their bills, and also remain in secure employment. And I think for me, that's really at the crux of this. There are other challenges as well. As soon as we started to do contact tracing like Leicester, as we got the data back in the summer, we started to see very clearly through the daily practice of our local contact tracers, those barriers that our residents were experiencing to isolate. We started to build a really strong picture of that. We augmented that towards the end of last year with a survey that just really hammered home that point that was being made, that we could see, that our contact tracers could see on the ground, that financial barriers, concerns about losing work, practical issues such as how am I going to access food, were all issues that people faced as barriers to isolation. But it's not just that they face those as barriers to isolation, they would face those as barriers to get a COVID test in the first place, because they didn't want to face the incredibly difficult consequences of what a positive test would mean. Next slide, please. So we started to think increasingly about health protection in the same way that we think of so many other public health challenges, through a social lens, one that is equally in the same way as non-communicable diseases is experienced across a social gradient in different ways. That if we were going to make health protection work for our local population, for them to test, engage with contact tracing and isolate where necessary, we needed to recognize the social and economic drivers of individuals' lives. We needed to build trust with people who have good reason to have low trust levels with authorities asking them to do things. We need to do things in languages that our community speak and build, and that's not just about making things understand, but it's also about building that trust. We need to wrap around support around people in individual ways. And if we do that, we're much more able to support people to do the steps that they need. And I don't want to pretend through this presentation that we've got that the panacea all exists at the local level. There are still significant, despite all of the work we've done, there are still significant barriers through social policy, through national policy, to address some of the barriers, that particularly financial barriers, that people face to isolate. But we've tried as best as we can at a local level to grapple with these. Next slide, please. Thanks. So this is all about, and there's a lot of parallels with what the colleagues from Leicester spoke about. This is about identifying people as early as possible and engaging with them as soon as we can. So in fact, that they know about the support that's on offer before they even get a test. That may help them get a test, but also means they come to us for support and assistance right from the beginning. So we make it really clear through all of our comms work, throughout the community, through displays at all of our test centres around the range of support that's on offer. And then as soon as we get a notification of a positive case, we do what we call a welfare check, which is we do that check-in with residents to understand whether they do have any barriers to isolate, and if so, what they do. And they can access support both from us as a local authority, but also we've commissioned a local voluntary sector organisation to provide another avenue of access to support. So, trying to, again, address those trust issues. We want people to get support from wherever they can, whether that's from us as a local authority or from a trusted voluntary sector organisation. And then the support that we offer tries to address all of those factors that are in our capability of control to try and support them to isolate. So making it as easy as possible to get the self-isolation support payment. It's not sufficient for many people, and I think that needs emphasising, but we make it as easy as possible for people to claim it and use discretion as much as we can. We also offer hardship grants through our voluntary sector helpline for those who aren't eligible for the self-isolation support payment. So we are trying as much as we can to address the financial barriers. We have mental health support through a befriending scheme that we launched through the early days of the shielding programme. We provide food to those isolating who need support to access food, and roughly to about 60 households a week currently getting that kind of support. And we also have this alternative accommodation offer. It was really important to us that we develop this because of the risks linked in our community to people in multi-generational households, but also the risks to the many younger people, younger households of HMOs, of shared independent, shared housing, that those risks are very present. So we developed a supported accommodation offer, which has been incredibly slow to be taken up by the community, but I think it is really important that we are on a learning journey with that. Next slide, please. Like I say, the whole point of this is to support our community to isolate. This is about building that trust and building people knowing in our community that we as a council and as a place working with the voluntary sector will do what we can to support people to take the necessary steps, that we don't want people to face the impossible choice between taking the appropriate public health action for their community and looking after their family as well. Next slide, please. Just to give a sense of the scale of this, just in the last, so we obviously had a huge peak in late December, early January. We had 5,500 cases in the first week of January. So since Christmas, we've had contact with 1,700 households through the welfare checks. The vast majority of the support that people need is around financial support, and of those we've spoken to through contact tracing, nearly 1 in 5 need some support, around some financial support, to be able to safely self-isolate. But those other needs also come up. We are supporting a lot of people around mental health, a lot of people around access to food, and like I say, we would like to be able to support people more in the future around alternative accommodation, and we're developing that offer as well. I won't talk through these in details. We've got tons of case examples with our contact tracing team who do an amazing job speaking to people day in, day out, collect these examples that speak to the individual barriers that different people, different households experience. So I'll leave these with you, and we'll send some more in if you want to add flavour, but I won't talk to them in detail. So just to end by saying, I think we are real evidence from these conversations that we are this connection built, that health protection needs to engage with these determinants of people's health. We need to build trust with our communities, and if we can do that, and if social policy can also take a step forward and provide people with the real financial support they need to self-isolate, I think we'll be able to much better support communities that face those difficult choices to isolate going forward.
Thank you so much, Jason, and thank you everybody for that very informative set of presentations on how Leicester and Newham are getting it right when it comes to test, trace and isolation. And I'm sure the panel have got questions for all of you as well, and I hope we can cover some of those. But right now I want to open up to questions from the public, because we have quite a few interesting questions coming in. So I want to start with Caroline Blake. Caroline, are you there?
Yes, I'm here. My question is, national test and trace has been allocated a budget of 37 billion. The Public Accounts Committee on the 10th of March this year said the unimaginable level of spending on test and trace made no measurable difference to the spread of the virus. My question is, has any of their budget been allocated to local authorities, who I understand, and has been demonstrated, I think, today, have made a measurable difference? And if so, how much?
Thank you very much for that question. I mean, certainly hearing from Ivan, it didn't sound as though there was any extra funding coming through. Ivan, would you like to respond to that?
So we don't. So I think when an area goes into local testing, we don't receive any additional funding because we're a local contact tracing area. So we will receive nothing over and above what you'll always get from your contained budget.
Thank you, Ivan. Does anybody else have any perspective on Caroline's question? I mean, it does make you wonder where all of that money is going. Anthony Costello, and I know you had some questions for the panel as well.
Well, no, mine was actually largely about this complete divide. You know, we're 15 months in. What Ivan and the team and Roxana and all the others, Jason and Edward and people have done is amazing. And it just shows you, if you get a team together, even a relatively threadbare under-financed team, you can work miracles. But we're 15 months into this. And these are probably two of the best public health, districts in the country. I'm sure there are others as well. But where's the 37 billion gone? Why aren't they funding contact tracers locally? Why is our Secretary of State about to sign another huge contract with Central Contact, with Serco and Citral? I don't know if anyone dares to answer this, but do you get any feeling that Central Public Health are strongly arguing for local investment? And if not, or the medical or scientific advisors, or is there an absolute block at the political level? I find this incomprehensible and worrying, but you're doing an amazing job.
Thank you, Anthony. And that really is putting the ball back in your court, Newham and Leicester. I mean, I wonder, Roxana, if you've got a view on that.
Thank you very much, Alice. And I know that Jason will want to add, because he can talk through the specifics of the public health allocation. I mean, I know this, that in terms of the additional cost of COVID-19 to Newham, given the fact that we are a high deprived area, we've had to make, even before COVID, some £45 million worth of savings. That was last year. We've noted a shortfall of some £15 million, notwithstanding the government saying to every single leader very early on last March, do not spend, you will be resourced exactly at the scale that you need for us to contend with this challenge, and that simply hasn't been followed through. There's a curiosity around the funding formula that's applied to local councils, and we've had to recently pass a budget whereby we've had to find an additional £15 million worth of savings, and notwithstanding the lack of clarity around the public health allocation, we've put aside £31 million for our own public health budget locally. And obviously we can leverage money from the health partnership locally via the health ecology and working closely with our Newham CCG, but it simply isn't enough given the scale of health inequity that we are challenged by, that exposes our communities far more in terms of the COVID-19 impact. But Jason may want to add.
So I think it's just important to add that we have been given a resource through the Contain Outbreak Management Fund, and that is the resource that we're using to fund the supported isolation work that we're doing in Newham. But I think it has to be seen across local authorities across the country in terms of the context that Roxana spoke about. So local authorities making very difficult choices. We've absolutely committed locally to do everything we can to protect our local population, to navigate the challenges of the pandemic, and so using what resources we can. But I think it needs to be understood in that broader context.
Thank you very much, and thank you for that question, Caroline. I'm not sure that we've actually answered your question, but we've explored some of the funding issues, certainly. Moving on now to a question from Sophie Sweetman. Sophie. We can hear you.
Yeah. Hello.
Hello.
Yes. My question is, how is the test and trace system set up to cope with surges in the virus from variants? As I'm worried it would be wound down and won't cope with these dangerous variants testing and asymptomatic transmission.
Thank you very much, Sophie. So does anybody have any perspective on that? How is test and trace coping? How is it designed to cope with surges associated with variants?
We can certainly talk about it locally. So
Thank you, Ivan.
I think Ed alluded to this. One of the advantages of having it at the local area is that you can get people, if you've trained sufficient staff, they can be doing their day job. But actually, when a surge comes, because they're trained, we can drop certain things to bring about capacity to meet surge testing. So for us, it's been really important that we've got a flexible approach. So Ed will have a core team of people that he will deal with, and we'll deal with the day-to-day cases that come in. But if we had to, if there was a variant and we needed to pull together surge capacity, we could pull together, 100 people to get out there and do that kind of testing if needs be, because we are pulling from a council resource for a short period of time. And that's where your efficiencies come in, actually, the ability to stand up and stand down. But when they're stood down, they are doing other things in relation to council business.
Thanks.
Thank you. And is anybody able to give a national perspective on this, how test and trace copes with new variants emerging? I'm looking around to see if anybody else can help answer Sophie's question. Gabriel, do you want to comment at this point?
Well, I think it's going to be extremely difficult, and I do worry about the split responsibilities that we still see in the system between local authorities, Public Health England, NHS England, and the ability to mobilise. But with the difficulty with mobilising staff is, I think I heard school nurses mentioned earlier, we've got so poor levels of staffing now. I checked at the beginning of the pandemic, and we have 2,000 school nurses for the whole of England. 10 years ago, it was 3,000. In New York, one of the first things they did when the pandemic started was they recruited more nurses so that they had a full-time school nurse for every school. That level of staffing is actually what is needed, but it's unimaginable here. I think we just need to sit back and think about how impoverished our system is.
Thank you very much, Gabriel. Thank you for that question, Sophie. The next question comes from Gemma Sewell, who is the co-founder of Parents United UK. Gemma.
Hello. A recent flurry of scientific literature on the subject of aerosol transmission is a positive step in developing understanding of the spread of COVID-19. What needs to happen now to build public acceptance that fresh air everywhere is essential to pandemic recovery across the world, and to ensure effective mitigation of airborne transmission risk in workplaces and public buildings, including schools?
Thank you very much, Gemma, for that question. I will come back to you, Gabriel, but I'm going to let Professor Martin McKee start.
Yeah, thank you. A really, really important question. And I think the first thing that we need to get to happen is for authorities internationally, including WHO and within and at national level, simply to accept that the evidence is now here. We were all flying blind at the beginning. We didn't know, but the evidence has been accumulating rapidly. The difficulty is, of course, that there are the changes that will have to be made to accommodate this are quite substantial. And you can see that, people who own buildings will be reluctant to spend the money on particularly getting ventilation when they've built buildings where windows don't open, to put in filters and do all the other things. But I think what has been really quite remarkable is the way in which so many people who have staked their position against aerosol and airborne transmission have been so reluctant to accept the evidence as it's been emerging.
Thank you. Professor Stephen Reischer.
One of the things that happened after the Spanish flu a century ago was a change in the way in which we thought about nature and the way in which we thought about our buildings. There was a back to nature movement. Houses were redesigned. They were much more airy. They were much more ventilated. You moved away from the stuffy Victorian parlour to much more open spaces and well ventilated spaces. And we need a similar shift now. It needs to be a cultural shift. But if you want that cultural shift, of course we want to change behaviour. But to change behaviour, we've got to change environments, and that's got to be funded. And we need to fund that all public buildings have got decent ventilation, and we need to keep people safe by funding them to allow them to ventilate their own homes. And I mean, I must admit, I'm not optimistic given what we saw yesterday with the law on cladding, where the government isn't prepared to pay for people to have houses that are safe so they don't risk another Grenfell. But we need a government that is prepared to make people safe, to pay for people to be safe, to reconfigure our environments so that they are well ventilated and that we minimize the chances of infection, whether it be in this pandemic or in future possible pandemics.
Thank you, Stephen. And Gabriel, you can get your word in now, and then Susan, I'll be on to you.
Well, my words are actually the HSE, the Health and Safety Executive's words. If you go onto their website and you look under coronavirus and you look on ventilation and air conditioning, it starts off, their overview starts with these two sentences. The law says employers must make sure there is an adequate supply of fresh air, bracket, ventilation, close bracket, in enclosed areas of the workplace. And then the next sentence says, this has not changed during the pandemic. They're right, it hasn't changed during the pandemic. The law is still there, but what hasn't changed is ventilation practices. And I think it's incumbent on people to take matters into their own hands individually and collectively and make it very clear that they shouldn't be expected to work in stuffy environments where there isn't good ventilation. They should know for a workplace or a classroom or where they're being taught, or in a university, they should be able to know what the state of ventilation of any room that they have to work in is like. And that should be documented, and it should be available, and it should be inspected. So there is a legal requirement. HSE says there is a legal requirement, and we should be looking very hard at how that is enforced, because it certainly should be. It's very important.
We've heard before at these briefings, actually, haven't we, of the many complaints in their tens of thousands, if not hundreds of thousands, that have been submitted to HSE over the course of the pandemic, with very little seeming to happen. I'm now going to invite Susan Mickey, Professor Susan Mickey, for her perspective.
Thank you, and thank you for the question, really important. The last data I saw suggested that the majority of people still don't really understand that transmission is so much more likely indoors compared to outdoors. So still don't understand the importance of outdoors and under ventilation. And I think that in addition to everything that's been said, I think given the government really stressed the hand washing at the beginning, and scientific knowledge has moved on. So now we understand the primary transmission is through aerosol. The primary transmission isn't through droplets on hands. There needs to be a very, very active, imaginative, engaging public information education program. And in order to achieve its objectives, it needs to be done alongside communities. You know, we've often talked about this importance of co-producing, co-creating material so people can really understand the switch of message. And using visuals in communication is really important. So people are aware of how far cigarette smoke goes. You know, that people can picture that. Having an idea of making aerosols visible to people also, I think would really help. So I think this has to be, like so many things, multifaceted if it's going to be effective. But given we've got the summer coming up, now is the time to really do this and really stress, you know, if we're going to subsidise, let's subsidise pop-up cafes and bars, etc., outside this year and get it right this summer.
Susan, I accept that a lot of this is about information and education, perhaps, but I think, as Stephen pointed out, unless the environments are there to help people make the right choices, it's very difficult, isn't it? Placing all of that burden on individuals, asking them to make those choices when actually the environments are not helpful.
Absolutely. Sorry, I started off by saying I completely agree with what everybody else said. I didn't want to repeat that. So in addition to that, people are visiting each other's homes. And so, you know, this point is really important for homes. If you're visiting another home or people come into your house from outside your household, just make sure the windows and doors are open, just in case that person happens to be infectious. So it's not one or the other. These things really interact with each other.
Thank you very much. Does anybody else want to comment on this particular aspect? Dr. Taluna Oni.
Yes, I will just close the triangle that both Steve and Susan have drawn, because we've talked about the environment and the policies around that being important, and the individual behavior and messaging around that being important. I think the third part of that triangle is ensuring that they are aligned, because and in time and space, so that we're not at the same time as we're creating this messaging around what people should and shouldn't do indoors and outdoors, is the same time as we should be putting in the measures in place, because they speak to each other. And maybe just to highlight that, you know, Steve, you gave the example of historically, you know, getting it right in terms of having the policy change. We also have examples historically of not getting it right. You know, we had the England in the throes of the tuberculosis epidemic in Victorian times, about the same time as the windows taxes were being put into place, resulting in people bricking up their houses and reducing ventilation. So we also have that historical precedent, and it's important that we don't look back at what we've done now and think think about that dissonance between what we're actually putting into place now. And maybe I will just say that there are Windows type taxes, and there are taxes that are tantamount to those Windows type taxes. So if we think about the inequality in access to those public spaces that people have, you know, these are taxes that we're placing on the ability to embrace healthy behavior. So it's important that we think about that connection between the environment and behavior, and actually make those healthy environments more accessible and more equitably available to everyone.
Thank you very much, Tallulah. And I think when it comes to schools as well, we are perhaps missing an opportunity to have improved the infrastructure that would actually make schools healthier in all sorts of ways, because, you know, that infrastructure is rather tired in some areas, as we know. Another question now then from Georgina Fellows. Georgina.
Hello, everyone. Can you see me? Hi. I just want to ask a question about the daily testing trials that are currently going on in schools. My son's school is part of the trial, and I've got a question about whether the trials are ethical, because we're not getting parental consent for everyone in the school that's involved, just the people doing the actual testing. And also, is it safe, because people are not self-isolating, they're using lateral flow devices daily instead and returning to the classroom?
Thank you very much, Georgina. So this is the trial that's being run where the aim is to look at whether lateral flow device testing can be used in place of isolation. So close contacts are returning to school, but being tested rather than isolating at all. Who would like to start with this one? I'm wondering if, Stephen, you might want to take this first.
Well, Zubaydah's been leading on this. In fact, we met with the NHT to discuss this precise question. And as I say, Zubaydah was instrumental in that. So perhaps she would like to start.
She's not with us right now.
Oh, isn't she?
No, so I wonder if you'd like to be, if you
Okay.
could help take us through it, Stephen.
Well, I will channel Zubaydah. So one of the big issues in any form of research is informed consent, that people must know and must have choice over what they're letting themselves in for. And the question here is, who should you ask that informed consent from? Should it just be from those involved in the trial, or should it be from, for instance, children who are in the classrooms who might be affected and might be infected if the lateral flow tests aren't affected? And then on top of that, what would happen if somebody got infected? What would the implications be in terms of liability and legal issues for the teachers? And more, actually, head teachers and other teachers do become legally liable. So I think there are big questions here of liability. I think there are big legal questions. I think there are big ethical questions, because I think everybody in this school is affected in one way or another. In a sense, they are implicated in the research. And therefore, I think that all parents should be asked. I think there has to be informed consent. Having said that, I'm not against the research per se, because I do recognize, I think we all recognize, that many children being off school is incredibly disruptive, that it does have costs in terms of mental health, it does have costs in terms of education, it does lead to huge inequalities. So the question of how we could limit the amount of disruption and the amount of time in which children are off school, I think is a genuinely reasonable thing to do. And I think it's reasonable to do research on it, but it must be done ethically. And the other point is that if we are concerned about the disruption, and if we are concerned about the inequalities of children being off home, if that's genuinely the issue, then there are other things the government should be doing that we've called for consistently over months and months, like, for instance, making sure that all children have got connectivity, that they've got the hardware, that they've got the spaces where they could study, that they've got the support, that they've got people checking up on them, that there are not only nurses, but counsellors in school to support children. So absolutely support the philosophy of minimizing disruption to children, but there are many things that should be done, and this research must be ethical, and there must be informed consent, and it must be from all parents in the school.
Thank you very much, Stephen. And I think that echoes what my colleague at the University of Birmingham has said about these tests as well, Professor John Deeks, who has also raised concerns about the ethics of such a trial, which clearly affects everybody in the school. And so informed consent should extend to everyone in the school and not just the staff. Professor Anthony Costello.
I think Zubaydah's back. Maybe we should let her come in.
Zubaydah, we've just had a question about the trials in schools from Georgina Fellows, who's asking about these trials where isolating close contacts is going to be replaced with lateral flow testing. And she asked, are the daily testing trials ethical, and should everybody in the school be giving informed consent? So I wonder if you could quickly summarize your perspective on that for us.
Oh, absolutely. And sorry, everybody, I had to do a quick BBC interview. Oh my goodness, these trials are absolutely mind-boggling, and mind-boggling, Georgina, exactly for the reasons that you've suggested, which is they're an absolute ethical nightmare. They're an ethical nightmare. They're a logistical nightmare. Methodologically, they have so many holes. I'm stunned that they've gone through any ethics committee, which raises questions about Public Health England's ethics committee, which is what I understand it's gone through. But yes, absolutely. There are huge questions to be asked around informed consent. I think, the consent at the moment doesn't look like it's informed because there's not enough detail about these tests, trial tests in schools. And just to make it clear, these trial tests are about comparing, essentially about testing whether lateral flow tests can replace self-isolation. But there's issues around consent and who they're asking, because they only seem to be asking those who will be contacts of positive cases. but not asking the rest of the children in the classroom, let alone the whole school population. They certainly don't seem to be doing any kind of risk assessment of extremely vulnerable families that are linked to the school. And that raises huge questions. And I think it raises questions about who the participants are. They seem to have, interestingly, defined participant as only those who have given consent, which only seem to be those who are in close contact. It is astonishing that this is happening in 200 schools. These apparently are schools that have just come forward. They're self-selecting, which raises all sorts of methodological questions about sampling. And that's important because if this study gets rolled out, if lateral flow test as a replacement for self-isolation gets rolled out across the country, we need to keep in mind that approximately a third of secondary schools and a quarter of primary schools have children from Black and ethnic minority backgrounds. And we know that people from Black and ethnic minority backgrounds are more vulnerable to this virus. They're more likely to be hospitalized and die from this virus. We also know that people in deprived areas are 2 times more likely to die from this virus. So there are huge, huge questions. But believe me, Georgina, we will be pursuing this. We're having lots of meetings. We're extremely concerned. And we will be asking more questions of DFE and Public Health England.
Thank you very much. Thank you.
Thank you, and thank you, Zubaida. I'm so glad that you reappeared just in time to answer that question. Moving on to, I'm going to try and squeeze in 2 more questions, everybody. So let's keep it nice and concise, both in the questions and the answers, please. John Dagpano. John, are you with us?
Yes, can you hear me?
We can, go ahead.
My question refers to the discussion last week, in fact, about transmissibility of new variants, and in particular, how one can stop a more transmissive variant becoming the dominant one. Now, last week, IndySafe said that the B1617 Indian variant was more transmissive than the Kent variant, and perhaps more lethal as well. Surely this means that for the UK, that unless one can selectively drive down numbers of the Indian variant to virtually 0, it will eventually become the dominant variant. And that will happen very quickly, perhaps in a matter of weeks, as happened with the Kent variant. And all this would increase the basic reproduction number. And once that has happened, we are stuck with that forever, regardless of vaccination, lockdowns, or the current prevalence of the disease. So I'm just wondering what the panel's view on this is.
Thank you very much, John. And it looks like Dr. Kit Yates has a view.
Hi, John. Thanks for the question. I don't think it's been definitively established whether it is more transmissible or more deadly yet. It seems potentially that is true, given what we're seeing in India, but I don't think that the scientific evidence is there to back that up. Of course, if it is the case, then it's a worry. Obviously, we need to do everything we can to try to make sure we don't have community transmission of this variant and, of course, the other variants, which potentially have impacts which might allow them to evade vaccines as well. So we need to be a little bit cautious. Not that much is known about this new Indian variant B1617, but that's not a reason to not be cautious about this. It's in fact all the more reason to be more cautious about it, if anything. So I think we need to gather more evidence, but while we're doing that, we need to be extremely cautious and careful and making sure that we are taking measures on our borders to make sure that we aren't importing new cases of this variant.
Yeah.
Thank you very much, Kit. And Martin, you'd like to comment too?
Yeah, and I think it was me who said something last week, because both Christina and I had just literally got 2 graphs in separate ones as we were actually on the call, on the Independence Age call. But I agree with Kit. You know, it looks like it may be, but we're not absolutely clear yet. But I think the real message here is that we need far more sequencing, because it's really difficult to disentangle whether it's being sort of appearing to be more transmissible because it's being carried up by the outbreak, and particularly in India, where there's very little sequencing, and what is taking place is different in different parts of the country, and you know, it's an enormous country. So a bit of, I mean, I think I was the one who said it, so a bit of caution. That's what it looked like last week. I think it probably may be, but we're not absolutely certain.
Thank you very much, Martin. And I'm going to squeeze in a very, very short question and answer here.
Sorry,
Joan 12. Joan, are you there?
Yes, I am. Thank you. I'm speaking on behalf of Zero COVID campaign, and I'm taking us back to test and trace, if you don't mind. We've been campaigning this week alongside with We Own It for Serco's contract not to be renewed and for those billions to be redirected to local authorities. And we want to know what the panel's view is if we actually are successful in that, and if we can get more and more local authorities actually doing test and trace, whether they think that will be sufficient to prevent a third wave hitting us at the end of the summer.
Thank you very, very much, Jane, for that interesting question. I wonder if I could start with some of our special guests from Leicester or Newham with that one. Jason, are you still with us?
Oh.
What do you think about Jane's idea then of rechanneling that funding to regional test and trace?
So I think we're really supportive of more of that funding coming locally. I think we can achieve an awful lot locally. I wouldn't go so far, Joan, as to say that I think that alone can avoid a third wave. I think there are clearly a lot of tools in the toolbox that we need to be using. Vaccination is going to be absolutely vital. I think so I think there's a whole, and all of the measures that people need to continue taking around social distancing, around some of the issues around fresh air that we talked about earlier. All of those things we're going to need to use all of the tools in the toolbox to try and mitigate the risks. But I do think that the more that we can build that capability at a local level so that we are getting to people quickly and supporting them to isolate would be hugely beneficial.
Can I just ask if there's anybody on the panel who thinks this is a bad idea of Joan's? Does anybody think it's a bad idea? I'm looking around. I think everybody thinks it's a great idea, Joan. Good luck with it. I would like to just pick up on this issue of the third wave, though. I mean, where do we stand with that? Do we think this is likely? Is it inevitable even? Are we able to predict whether it's going to be subtle or massive? I wonder if I could come to you, Professor Carl Friston, for a bit of insight there from perhaps a modelling perspective.
From the modelling perspective, you'd have to answer the questions that we've just been asked by John and Joan. So the answer to the question, what can we do about fluctuations in the transmissibility of the virus due to new variants, I think is quite a simple one. You just reduce the transmission risk via aerosol transmission by going from 1 meter to 2 meters, wearing a mask when you think you might be infected. So just normal personal mitigating behaviors, sensible behaviors, will in principle offset increases in transmission and certainly be easier during the summer than in the winter because we're all outside. So those personal mitigating behaviors that will likely endure beyond June the 21st, if we assume that they are at the current level, and we assume that the local outbreaks can be contained with Joan's excellent suggestion. You're absolutely right. The way to keep on top of this, as Jason says, is to supplement the reduction in transmission risk through personal mitigating behaviors and vaccination with local contact tracing. And if that works, then the modelling suggests there's a very small possibility of a surge after the summer, if those two things are in play. The only thing that can go wrong is that the government does not properly enable and finance local action through the kinds of initiatives that we've heard about today, or there is a massive increase in the viral transmission due to mutations. However, if Dean was here, I think he'd have something reassuring to say, and then he'd take it back because he's such a gentleman and a scholar. So I'll finish there.
Thank you very much, Carl. I think, Gabriel, you'd like to get a quick word in here.
And my final word is, I'm not sure we should be having the debate about whether it'll happen or not. What we actually need to do is assume that it might happen. I mean, this is how we got into this mess, by not being prepared. So we need to be prepared. If there's the slightest risk of it happening, then we need to be prepared. So we need to do lots of stuff to make sure that if there is an upsurge, that we're on top of it quickly. and we responded adequately. But one of the things we could do to stop it would be stop treating the entire country as if it's all the same, because it huge ranges now in terms of the level of infection. And there were huge ranges when we came out of the last lockdown last summer, and we know what happened. It was the areas of high deprivation, of overcrowded housing, and of high levels of BME communities. Those are the ones that took off. So we should be putting our preventive measures in place now in the hope that we can prevent a third wave, not spending a lot of time speculating on that.
Thank you very much, Gabriel. Oh, Anthony, all right, squeeze something in.
Just very quickly to say, as long as the world remains unvaccinated, we will have a continuing threat from new variants. COVAX is failing because it's not being supported. They've got less than 1 in 5 of their planned vaccinations going out around the world that were planned for this month. We're failing miserably. We've had a year to sort this out. The only solution, in my view, is a patent waiver, and that we have to allow all the vaccine production companies around the world to be churning out these vaccines. Otherwise, we're going to be in a mess for years.
Yeah, absolutely.
Thank you very much. And thank you very much, everybody, for a fantastic discussion here. I'm going to have to draw it to a close. Thank you, everyone who's watching. Thank you for the questions that have come in. Thank you very much to our special guests from Leicester and Newham. And thank you, Independent Sage. Today's session has stressed the importance of a functioning, effective testing infrastructure, and it's shown how this can be achieved and made even better, actually, with additional funding, with those examples of best practice that we've heard from Leicester and Newham. As we work out together how best to tackle this ongoing pandemic, it's really, really important to share and highlight success stories like these, because we can learn from them, and that will make a difference. These regular Independent Sage briefings are a platform for dialogue, of course, but also a way of making sure that we can share useful, potentially life-saving information and get that out into the public domain. And we'll continue to do these briefings for as long as it's needed. All of the experts are volunteers here. If you want to find out more about their experience, their expertise, go along to the Independent Sage website, where all the reports are on as well. And do follow us on Twitter and on Instagram if you don't already. We'll be back same time, same place next Friday. And stay home if you can. Stay safe. Keep well. Thanks, everyone.
Thank you. Bye, everybody. Bye.
Thank you. Bye.